All set.
Right. Do you see my slides and my slides only?
Yeah.
They're loading.
Let me know when you see them. So you do
Yeah,
or do
still-
not see them?
It's still loading. Yeah, it's not up yet.
Okay, I don't know why that would be.
Hmm.
One
It says
second.
double click to enter full screen mode. I don't know if
Mm.
I think that's for us. Yeah.
oh
Let me see.
oh I
Okay,
see it.
good.
Great.
Okay,
Okay.
good.
Yeah.
Right. Do you still see my slides and my slides only?
Just that. Yeah.
Yeah.
Okay, cool. All right, so let's talk about Clozapine life after REMS. Oh, go back. All right, overview of today's presentation. Again, first we're going to talk about the background of REMS and what led to the decision to institute a REMS program, talk about current practice guidelines. Next, we'll talk about some evidence as to what led to the decision of REMS being discontinued. Again, just some brief background. And then we'll move on to some updates around clozapine monitoring and clozapine usage and what has been going on here in the US and what has been going on around the world as well. And then lastly,
And
we're going.
the slides aren't advancing if you're changing from the
Okay.
title.
All right, give me 1 second. Did it advance?
Yeah.
Yep.
Okay, great. All right, tell me if there's continued issues there, okay?
Yeah. Thanks.
All right, awesome. And then lastly, again, we'll talk about your experience, everyone's experience on the call with REMS. I'm really curious to hear what hospitals are doing and instituting, and I'll talk a little bit about what BI is doing as well and the updates on that on our side. All right, first, some background. So REMS ended in February of this year, and it completely ceased by, hold on 1 second, guys. All right, there we go. I completely ceased by June of this year. The rationale behind this was that FDA determined that clozapine REMS is no longer necessary to ensure the benefits of clozapine use and that the benefits outweigh the risk. The expected impact of this was to decrease healthcare, decrease burden on the healthcare delivery system and improve access to REMS. However, this was in the context that the risk of severe neutropenia with clozapine would still, of course, still exist with medication use.
I might
this is
want to say a little bit about the history of how, unless you were going to say how it got discontinued.
Yeah, I could talk a little bit about that.
Yeah.
The decision to discontinue REMS was really an advocacy of families and patients. Families recognize the fact that clozapine is an invaluable tool in the treatment of psychotic disorders and that patients do very well on it, and that especially their children, talk about parents specifically, but parents realized a lot of the times clozapine allows their adult children and patients themselves recognize that allows them the best chance at functionality, and that this REMS monitoring system just provided this huge barrier to access for a lot of people. So families were really the ones spurring on this change. So when the FDA held here, I believe the FDA held hearings, at the families and patients came out in full force, just really wanting this change so that more patients would have access to REMS.
Yeah, just to add some spice to that.
Yeah.
Families banded together under one group called Angry Moms.
Angry Moms, yes.
Yes. So, and they allied with the SPA, which is Schizophrenia and Psychosis Action Alliance, which is a national organization similar to NAMI, but driven by people with lived experience. And I happened to be on the board of that SPA, and so was kind of involved in some of these discussions going forward with FDA. And then they succeeded, which was great news.
This is great news. I would agree.
Yep.
This is a picture of my pharmacist friend that does a lot of advocacy work for Clozapine in Kentucky sent me the day REMS was discontinued. So I wanted to include that.
That's
I'm very happy about that.
cool.
Okay, so let's talk about current practice guidelines. With REMS being discontinued, Clozapine practice guidelines changed in some ways and didn't change in others. And again, I think we're all familiar with these, but I wanted to just do a quick refresher. So what changed when REMS was discontinued was that prescribers, pharmacies, and patients no longer required to participate in REMS. Pharmacies no longer needed an ANC before dispensing Clozapine. Pharmacies no longer needed to submit ANC results to the Clozapine REMS. Prescribers no longer need to submit patient ANC results. And lastly, pharmacies no longer needed to obtain a REMS dispense authorization. But what stayed the same is that monitoring guidelines stayed the same. So timelines around that, and that baseline, and again, included in that is that baseline ANC must be at least 1,500 for the general population and 1,000 for patients with documented BEN. And all of the boxed warning and prescribing information also remain unchanged. Let's talk about some evidence for the changing of the monitoring schedule. And these were some articles that Kesh sent out a little bit earlier today. The first one is entitled "The Timing and Severity of Clozapine-Associated Neutropenia in the U.S. Is the Risk Overstated?" So this study was a retrospective cohort study of 974 patients who received Clozapine at Johns Hopkins, and in 2013 to 2023, 287 of those about 900 were new starts. And the demographics were 51.1% white, 39% Black, and new starts were more diverse. Key findings in this study were that 0 patients of the 900 developed severe neutropenia, defined as ANC less than 500, out of the 974, and only 59 of that 974 developed any neutropenia, including mild or moderate. And of the 59 that developed neutropenia, 9 of those, only 9 developed moderate neutropenia, defined as 500 to 1,000, while 50 developed mild neutropenia. And then out of the 29,000 total ANC measurements in the study, only 207, which is about 0.7%, were below the 1,500 ANC 1,500, which is our marker for low for neutropenia. So in general, again, it just proved that this fear of severe neutropenia was a lot rarer than expected in the real world. So we're not seeing this as much. We are seeing neutropenia, of course, in some patients, but we're not seeing it to this grand extent. And so considering that, it's of course worth considering, should we change the monitoring schedule? What really is going to serve patients best? Balanced with the true clinical risk of this occurring. It's also important to notice that most neutropenia occurred in the first 8 months of treatment, so very early on, and only 5 developed neutropenia after 2 years. So again, that's 5 out of 974. Another article that talks about the risk of agranulocytosis with Clozapine, and this study was in Finland, and this is published in Lancet Psychiatry in 2024. The study compared risk of neutropenia for Clozapine to other second-generation and antipsychotics. This study the timeline was 1972 to 2014, so a very long stretch of time. Patients with a history of agranulocytosis were excluded. Essentially, the peak agranulocytosis rate for clozapine occurred in the first 6 months and dropped dramatically after that. So again, it's reflecting that same finding that the severe neutropenia and neutropenia in general is a lot lower than initially expected. Right. And this is the third study that Kesh sent out today, which is instead of looking at patient experience and neutropenia, looking at physician experiences with clozapine prescribing. And this was published in JAMA Network, Open Network in 2025. This survey was in the REMS era. It was conducted in May of 2022 to January 2023. And it was a survey of 196 US physicians who prescribed clozapine. And the key findings here were satisfaction. About 64% agreed the positives of the REMS process outweighed the negatives. Another finding was that 68% agreed that blood testing requirements outweighed the negatives. Positive aspects of the REMS system, 92% found that the certification information was clear, and that 75% found that certification provided useful drug information. Some of the challenges identified by the physicians surveyed included that 60% reported frequent delays in medication access, which, I mean, to me, that's a huge deal. If patients can't get their medicine, especially patients with schizophrenia, then it's a huge, huge deal. So 60% reported frequent delays. And 71% actually reported that the REMS requirements were burdensome to patients. Interestingly, doctors more likely to have a negative REMS view were white physicians versus physicians of other races and newer physicians as well. So defined as people who had been practicing less than 15 years. So, and then as far as clinical risk, of course, 64% ranked severe neutropenia as their biggest concerns. About clozapine use. And then as a summary, most of the survey respondents were satisfied with the clozapine REMS program, but highlighted the need for enhanced educational materials and administrative efficacy. Let's talk about some updates. And I think I lost a slide here, so I might have to go to my notes and read a few things. First of all, so these are the European Medical Association, the Pharmacovigilance Risk Assessment Committee, or the PRAC. They just put out new guidelines for European monitoring of clozapine in early July of this year, based on some of the evidence we talked about before. So based on that, even though clozapine-induced neutropenia can occur at any time in treatment, it is predominantly observed during the first year, with incidence peaking in the first 18 weeks of treatment. After the incidence decreases, it becomes progressively lower after 2 years of treatment in patients without previous neutropenia. Therefore, they recommended less frequent blood count monitoring. And as you can see here, this is their new guidelines compared to ours via the current US clozapine product label. They recommend weekly for the first 18 weeks, and then monthly until the first year, and then going from 52 to 104, so year 1 to year 2 quarterly, and then from then on they recommend annually. So quite a change. And again, they're kind of like spreading weekly early on, and then they're spreading it out sooner after that. And then I don't know where my slide went, but the newest guidelines, there was a new Delphi study, I'm going to explain this because I didn't know this, but it's like essentially a survey-based, it's a survey-based way to get new recommendations. And a Delphi study held earlier this year and published in Lancet Psychiatry, July of 2025, also put out new recommendations. And I'm trying to find that. Here we go. Okay, here we go. So again, this was published in Lancet Psychiatry. I'll try to share my screen so you guys can see this too, because I think it's worth it. It's important. Let me see. I have a million tabs open, so I'm trying to find it. Yeah, here it is. Okay. All right, so this was published in Lancet Psychiatry, July 2025. So this was a worldwide panel, I think of 100 and let's see if it's here. This is just a summary. I had the full text open somewhere, but I can't find it. So this is of 100 and maybe like 9 psychiatrists who most of them have been treating. I think a requirement was you had to be treating patients with schizophrenia over 10 years. These are some of the authors, but their recommendations were interesting as well because they're recommending discontinuing ANC monitoring after 2 years. But then in another part of the article, it says discontinuing after 2 years, but consider monitoring yearly for hematologic abnormalities. So, but overall, they're not making like a hard recommendation. And then also let's see if they have their timeline on this. Again, I apologize for not having the full text up. I thought I had a slide on this. What I thought was interesting as well was they're really focusing on side effects of clozapine as opposed to just pure neutrophil monitoring. They're recommending doing metabolic labs every 3 months and on every appointment, really drilling down on that side effect profile. So constipation, acid reflux, sialorrhea, nocturnal enuresis, tachycardia, sleep apnea, sedation, etc. Except they couldn't really agree on if an EKG was a necessary part of monitoring. So that wasn't included. But in summary, these new global recommendations that were published in the Lancet last month focus more on just general side effects and are talking about, again, spreading monitoring out and then considering discontinuing ANC monitoring after the first 2 years. All right, I'll go back to my slideshow now. One second, guys. Stop share. Thank you for your patience. All right, there we go. All right, you guys see my slides?
Yep.
Excellent. All right. So what we'll do now we're going to talk about, now we're going to move on to our discussion. So again, like, where do we go from here? I will talk a little bit about, I work at BIDMC and a little bit about what we're doing with clozapine REMS. I'm part of the panel that meets to talk about just within the BI system, how we want to handle this on a monitoring basis, because of course we do want to have our own way to ensure that people are ordering the correct labs for clozapine monitoring. So I think what we're going to be doing is essentially making an EPIC order set with that. So when you order clozapine, there has to be an ANC in the computer that's recent. And it also has like the order set for constipation, for some of the other PRN medications you may need with clozapine, and just in labs as well, like recommending that you order an A1C if there's not one in the computer, recommending that you order a lipid panel if there's not one in the computer. So again, just sort of facilitating our own monitoring. I think what's really interesting, and one of the concerns that a lot of people had when REMS was discontinued, was that everyone, meaning like individual hospital systems, are now going to have their own REMS, so to speak, or like their own clozapine monitoring system that's unique to them and that has their own specific requirements, and that it wouldn't, given that that monitoring wouldn't be universal anymore, that could potentially be problematic to patients. I haven't seen that yet, but I'd be curious if anyone else has, or if that's a concern that anyone else had as
Yeah.
well.
So, at this point, before you tell us about the BI proposal, we have Kamel Gerbi on the line, and maybe Kamel, you could say what are the DMH guidelines, if there are any. And
Yeah, I'd be
also
curious.
Lynn is on the call, and maybe Lynn can say a little bit about how it is at CHA.
Yeah, I'd be very curious to hear. Yeah, so I'll turn it over for a discussion. Thank you for your attention.
Sure. Hi. Yeah, thank you for the nice presentation. It's great actually to be able to discuss this topic. As you know, the main problem has been having patients agree to the treatment. It's been a challenge, and we know why. So good that we have more clarity and plans that we'll be able to implement it. For us, so far, we have not made any changes. So far, what we have done is our patients been coming for the blood work weekly for 6 months for the ANCs, and for 6 months, they will be, if all goes well, they move to every 2 weeks for, again, 6 months. And after a year, they'll be on the monthly schedule. That's what we do. And they have, we do twice a year. We get them like a metabolic panel. We check their hemoglobin A1C, lipid profile. We check their vital signs, blood pressures, weight, and all that. We follow that at any visits here. So when people stop taking their medication less than 3 months, less than a month, we just continue with the same protocol. But if it's more than 4 weeks, then we have to start from scratch. That's what we've been doing here at Mass Mental. So yeah, I think it would, if we are going to, mainly for the new patients, I would say, continue in some ways the regular schedule like we had so far, and after, because the risk is basically it's higher, as we all know, during the first year to 18 months, and after that we'll definitely have to consider reviewing and see what we can do with the patient that we have, because we do have patients who've been on clozapine for many years here, so and they call us the vampires.
Yeah, thanks, Kamel. I might add at this point that the American Psychiatric Association has come up with some guidelines as well, which is to continue with the same kind of REM guidelines, but without the no blood, no medicine kind of rules. Basically, as you said, Kamel, weekly for the first 6 months, once in 2 weeks for the second 6 months, and once a month afterwards, which is kind of conservative compared to what Europeans have been doing. And in fact, South Americans like Chile, they don't have an expectation at all after 2 years. In fact, I came up, if I may show one slide here, I came up with a graphic display of this across the world. So let's see here. Yeah. Do you see this? So
It's loading, but it's about to share. There it is.
yeah, so the blue line here is the American guideline, which is, it'll be a low frequency every 4 weeks after 1 year. Whereas that frequency goes up to every 3 months in some European countries. And in Chile, it stops. There is no need after 1 year to do anything. So there is a wide variation around the world. So just one point I wanted to make.
Gosh, I would say something too. I know the monitoring has been by itself, burdensome for everyone, But I tell you, the fact that patients coming to the clinic and the non-invasive part of it, the fact that they come and they be seen,
yeah.
actually helped a lot in
Of
keeping
therapeutic
them
value.
stable
A
in
lot
the
of it.
community. It's just the
Yeah.
monitoring,
No.
so, and getting the feedback. So
The other
we don't want to
thought I
lose that.
had,
That's another thing that we don't want to lose, because some patients are very hard to to maintain in treatment. We know how medication adherence has been a huge issue with the other medication that we use besides clozapine.
yeah. Do you connect their clozapine visits to any kind of group therapy or psychotherapy visits?
I think they meet with the nurse, and they're not like it would be a good idea to have a group. Actually, would probably be helpful to the nurses too, instead of having to see one. Especially if we're going to reduce the frequency. That's actually, it's a great option that we should consider. Something to discuss with
one
Jose.
other thing that I have heard is, I have a friend, Robert Lightman, who is the clozapine doctor of America, so to speak. He's written a book on clozapine, and he's a nephrologist. His son got dramatically better following clozapine, so he switched his career from being a nephrologist to being a clozapine doctor. So what he does is he does a monthly family group, and his argument is that clozapine treatment is best done in the context of a milieu where the family is also as involved with the treatment as the patient. And so he provides a lot of education and kind of a milieu-based, intervention with the groups containing both the patients and their family members. Once a month Saturday, one of my patients actually goes to that. She comes back with ideas, and so then it's become like a larger team taking care of him over the course of time. So that's another model that one can think of. But I think that, unlike the South American countries where they don't do anything after 1 year, doing something every few months is actually a good idea, because we want to monitor their metabolic side effects anyway. We want to bring them in for an HbA1c at least every 6 months or annually anyway. We want to be checking their weights and making sure that their constipation and the cardiac status is okay. So if you're bringing them anyway, doing a finger prick is not a great additional thing from a patient convenience point of view. So I would favor a periodic check in everybody. If not once a month, maybe once every 3 months, or once every 6 months.
So Kesh, let me chime in here and say a few things. I mean, first, you did mention just briefly now cardiac status, and I think, as for a physician who had a patient die of cardiac complication, I really feel strongly that we have to be monitoring cardiac status in these patients, particularly as they get older. That's one thing, but I just wonder, you presented such variation around the world, and I'm wondering if we could do some kind of study to see if it really mattered. Are patients on clozapine dying of undetected things because they stopped monitoring the blood, in South America, or does it really matter? I mean, are we, I don't know. I mean, I could tell you that what we're doing is similar to what you're doing, every week for 6 months, then every 2 weeks, and and then every month. But regardless of REMS, it's really delightful not to have REMS, because I think that stopped a lot of doctors from prescribing clozapine, because It's an extra thing that they don't want to be bothered to. You have to get on their website and enter things. And if the patient forgot to get their blood drawn to for a long enough period of time, you couldn't enter it. And it was a real struggle. So at Cambridge Health Alliance, we have a Clozapine group that a couple of pharmacists who they put in the blood orders, they monitor the patients, and they even meet with them on a regular basis to find out if they have side effects or whatever. So that takes the burden away from the psychiatrist. But and we're using it more often. I mean, we do have a protocol to try to get it for first episode patients now because they're more likely to respond to clozapine.
Those are great thoughts. So in regard to your cardiac monitoring, Glenn, I agree with you. The risk of dying because of a myocarditis is actually higher than the risk of dying out of a granulocytosis.
Yeah.
And so that is not given as much seriousness as it should. I have been seeing literature around the world that some countries have more frequent myocarditis than others. So there may be some regional variations. So there was a paper from Australia which was published in Schizophrenia Research a couple of years ago, which showed a kind of a 7 to 10 times higher risk of myocarditis in that particular province within Australia. So they were not sure why that was the case, but there may be some other environmental factors that might contribute to the risk of cardiac inflammation in the context of clozapine. So more research needs to be done on that.
On another topic relating to clozapine, I just accepted a paper to Psychiatry Research where they found a high frequency of polypharmacy in patients on clozapine. And, so that can lead to cardiac problems and everything else. But it's an indication that a large percentage of people on clozapine are not recovering. They still have symptoms, and so doctors are adding other antipsychotics.
Yeah, no, part of that might be because of the fact that clozapine has so many side effects, and every side effect gets a medicine added.
Yeah,
You get like 2 or 3 laxatives for the constipation. You get something for the drooling. You get something for the blood pressure changes, orthostatics, and so on. So
but
it
I'm
keeps
talking.
adding up.
I'm talking about additional antipsychotics, not all the side effect medication.
Yeah, that too. Yeah.
Yeah, and that may be also because of the sedative effect of clozapine. A lot of people can't tolerate how they just end up sleeping all day. And so rather than increase the dose of clozapine to get a clinical effect, a lot of people are adding other medications like Abilify or something else.
True.
I would add also a lot for patients, actually, the fact that they gain a lot of weight. We've seen a lot of patients getting sleep apnea, actually, and that's one of the causes for heart attack.
Yeah, that's very true too.
Yeah. I think it's just, you see somebody like life just changing over a few months, they become somebody else. And that's where we have to be really cautious about that, because we're creating more problems by trying to, I think the focus will probably be more like less on the positive symptoms, more on functioning, I would say. Even I can tolerate my patients having some delusions, some paranoia here and there, but they are able to function. They're able to walk, they're able to sleep, they're not sedated, they're not falling. I think that's what we maybe the focus until later on, but it definitely we're causing more problems when we think about it.
The amazing thing, though, is that despite so much more polypharmacy and the risk of increasing body weight and risk of metabolic syndrome, at least epidemiological data seems to suggest that, mortality is lower with clozapine than with other antipsychotics.
Is that right? I didn't know that.
Yeah. So this has been shown in huge studies from Scandinavia, for example.
Hmm.
Yeah.
Just want to point out, Sarah has a hand up.
Oh yeah, I just really appreciate the discussion. I'm working on a PAC team, so it's a little bit of a different in terms of the system. It's a little bit like we don't have people coming in and getting the monitoring. So they kind of have to go in the community and get it themselves. And I found myself in a situation where I have, for example, someone who was stabilized on the hospital on clozapine after a year. His risk is so high off the medication, and he stopped every other medication except clozapine, and he's refusing labs. And it's like, what do I do with that? And since the REMS kind of stopped, I've just been continuing it with him, kind of no monitoring, informing him of the risks. But it's been like a little bit unnerving, but it's just interesting because maybe it's better because he gets the medication in that case, but also these situations are starting to come up where people just can't or won't get the labs, and it's more of a risk benefit, like how sick are they versus what could happen.
Yeah, no, thanks for bringing that case. That's a dramatic example of how benefits could outweigh risks, even though there is a risk of him not being monitored. The very fact of him staying on clozapine and thereby staying psychosis free hugely outweighs, I guess, the risk.
Right. Well, and what are
This
the health
was
and
exactly the
safety
point that
risks
the
of
angry
untreated
moms
psychosis?
talked about.
Mhm.
It's exactly the point that angry moms, family member stakeholders argued with the FDA to get the REMS off the table.
Cheryl, not to put you on the spot because I know you just joined, but do you want to say a little bit about what MGH is doing?
Sure. Let me just quickly turn on my video. Apologies for joining a little bit later, but it has been really interesting discussion so far. We are actually with Dr. Oliver Freudenreich as well as Dr. Abby Donovan are amongst other things around training and consultation for treatment-resistant schizophrenia, are also trying to understand what makes a clozapine capable clinic. So this discussion around, what are the kind of like infrastructure as well as guidelines around monitoring is really interesting, and how can we kind of standardize or think of the key ingredients of what would make a clinic capable and comfortable to prescribe clozapine and continue, the management of people on clozapine as well.
Yeah, this is a very important point in context of the discussion that we were having sometime recently. Kelsey can say more about that, about the wide variability on clozapine usage across clinics. So it would be, interesting to point out that clozapine capability might have increased across the clinics after the REMS got dropped. And so less people should be hesitant about prescribing clozapine across the clinics. We've been seeing a wide variety. Some clinics like, the one from Corrigan has like almost, Chakaya, you might remember this, more like 40 to 50% of the patients are on clozapine. But there are other clinics where there is none on clozapine and so on. So there's a wide range of variability.
Well, and I remember when I was talking with Abby Donovan about this, she had said, it's not necessarily changing like who you offer clozapine to, but likely will change who picks you up on the offer and who actually decides to move forward with it.
Yep.
But yeah, the kind of maybe pre-existing hesitancy around clozapine might need a little bit more to change that. It's like the clinics that are comfortable and have been doing clozapine already are continuing to do that. But is this changing behavior in people who maybe were not as willing to prescribe it beforehand? It's not clear.
Yeah. Any other thoughts? Megan, you have any comments from the BI side?
Yeah, I guess like one thought that I would put out there is, and I've garnered this talking to colleagues as well, but I think it's made, even though the monitoring hasn't changed, it really has made it more, it's made it more, I don't know, I feel like it's easier to offer it in a way. Something I've recognized is that people will inconvenience themselves if it means a higher quality of life. And if it's indicated and the patient and their family really understand, like, hey, really, this is the best shot you have at this point at higher functioning and regaining some of your mental faculties. A lot of patients and families will inconvenience themselves. And of course, you want the monitoring schedule to remain the same as that is the current recommendation. But at the end of the day, having the flexibility of if the person does miss a dose because of transportation or miss monitoring because of transportation, and still being able to refill the lab, that's under my clinical guidance and my clinical opinion, and it's not that control isn't coming from elsewhere. So it's really nice for REMS to be gone. I'm really curious to see what they do with the monitoring recommendations. That'll be an interesting next step. But yeah, offer the clozapine. That's my final thought.
Yeah, the other thing that I have noticed is, the dialogue itself is different with patients. Instead of having to say that you are going to have this blood test once a week for the first few months, and then once in 2 weeks, and then once a month for a year for your life.
Yeah.
You don't have to say that anymore. You can say that, yeah, we would recommend this frequency of a finger prick for about a year, and then we can see how it goes, and you and I can have a discussion at that point as to how frequently we want to do it. In other words, move the discussion from this is the way it should be to we could figure out as we go along, kind of this narrative discussion. That's a big change in my view.
Kesh and Megan, are you still though really giving them good trials of 2 other antipsychotics first before you're putting them on clozapine? Because I wonder about the first episode clinic that you mentioned, Corrigan. If they have so many patients on clozapine, are they just putting them on it when they come and not worrying about responding to other medications?
It's a good question. We haven't asked that question to Maxwell, who is the psychiatrist.
Yeah, I wish he was on the
Could
call
ask him.
today, but yeah.
Yeah, I wish he was. He has usually some good, well thought out opinions, so we might ask him next time.
Yeah, I'm definitely still following practice guidelines and offering at least 2 trials of atypical antipsychotic before considering clozapine.
But
And even still, it's still like a careful consideration with the family. Sometimes it's a discussion over weeks over how we can make it work.
Even though there has been, discussion in the literature about whether that 2 antipsychotic failure requirement is too stringent, and whether one should consider in some people clozapine even after 1 antipsychotic, and so on. So I think John Kane is a proponent of the earlier introduction of clozapine in first
Right.
episodes. Yeah.
Yeah, I know, but I'm wondering also, when you give people oral medication, there's a good chance of non-compliance or they forget. And I wonder if patients should always be on a LAI first, and then if it doesn't work, switch them to clozapine.
Well, and that was actually the poster we presented a little bit ago, but looking at the prescribing practices. And it does seem like there are some clinics that kind of at the clinic level, this decision is made, not at the patient level as much, but there are clinics that are more likely to go to LAIs as like the next step, or clinics that are more likely to go to clozapine as a next step, which I found interesting.
Yeah,
and
that's actually what John Kane presented to us a while ago. He never got that protocol or that grant funded, but the idea was to give an LAI and 6 weeks, and if it didn't work, go right to clozapine.
also
Yeah, and it's
there
showing
was,
up in our data for sure.
there was this curious finding by ICRA that clozapine seems to be more often used by white populations, whereas LAIs are more in the African American population in our MapNet data. Something we need to understand that better as to why that is the case.
Actually, the combination of LAI clozapine for some patients would make sense. One is the profile of the medication now we choose with clozapine, and by experience, I know I was some patient who couldn't tolerate a clozapine at even at normal dose. I wouldn't even say higher dose. I was able to get them like something like 200, 250 milligram clozapine, but they have like Abilify injection together, and they were able to function better with less side effects. There's some benefit in adding both, but as long as we know how we combine our atypical psychotics.
Yeah, a lot of creativity goes in finding the right combination of the medicines and the right doses for each patient. So.
And if you guys remember, during COVID, actually, we were able to, for some patients couldn't make it for whatever reason to their blood work, we were able to skip up to 2-3 months.
Yeah,
sometimes.
FDA did make some concessions during that time.
Yeah.
FDA did make some concessions that, if they can't get a monitoring, we will still be okay and so on. Yeah.
And it did work.
It's kind of a trial run, it sounds like.
Yeah. Any other thoughts? Also, any topics like this that are of topical interest that we should be planning for the coming months?
I think we have to focus a little bit because our patients are still aging, right?
Yeah.
And been on antipsychotic medication for many, many years, and they're living longer comparing to the one that have not been treated. I mean, my clinic, people up to their 70s and on clozapine, and they've been coming. It's just how we have to consider now, because patients aging and dementia processes happening, and how we really think about how to really kind of lower those doses of medication. Because I remember I have a case of a patient that started having his schizophrenia when he was a teen, not like 16, 17, and then been working with me until he's actually up to 70. And over time, we have noticed a lot of changes in his behavior, pretty aggressive. And my fear was maybe he's having some frontal temporal dementia,
Yeah.
And I was asking anytime he goes to the hospital, can we do some brain imaging? And what I end up having is a patient with more clozapine. And it's like, no, please, he's falling. I don't want him to be on higher dose. If anything, I want him to be off meds if possible, or with the minimal medications that we can use. And yes, he had frontal lobe dementia. So we really have to be now more and more cautious to really screen for dementia for our patients, that we think this is the behavioral problem, but actually it's just they have right to have dementia, and all type of dementia can happen. And besides all the medication we're adding, so we have to be cautious about that. That's one interest I have, working with patients with schizophrenia who are now aging.
No, thank you. That's a very important topic. Even though these meetings are in the early psychosis, early course arena. But at the same time, your point is very important because some people with the psychosis spectrum disorders, especially schizophrenia, they have what you might call accelerated aging. They have the dementia precox-like syndrome with larger brain age gaps. Their brains are aging faster than their bodies, in a way. And that contributes to the cognitive declines. So I think at one of these meetings, we should probably focus on that.
Well, and Kesh, I'm thinking, I know you're organizing this panel for our annual conference around the Bridges to the Future, deprescribing kind of what happens after first episode and what is kind of the trajectory of, medication and all of that. Like maybe that could be a good conversation for one of these too.
Absolutely. And there is literature coming out that antipsychotics themselves, this is very controversial, that antipsychotics themselves could contribute to cortical thinning, brain atrophy. And some antipsychotics more than the others. It may be more true of the so-called first generation antipsychotics than the second generation antipsychotics. And that psychosis itself could be neurotoxic. The longer a person has been in a psychotic episode untreated, the more likely there is going to be brain atrophy. So that's a very, very important distinction. And as you said, the November meeting would be a good place to kind of have a discussion on those very important emerging topics. So Kamal, as some of you might not know, we have an annual the conference on early course psychotic disorders, which is coming up on November 3rd and 4th, which we'll send to everybody at Mass Mental as well.
Yeah, I'll put the link to that in the chat now just so that folks have it.
Thank you.
I think we're at 1 o'clock. And unless there are any other things people want to say, have a good rest of the day.
Thank you for the invitation.
Thank you.
Yeah, thanks you guys.